So hello and welcome to the Hooked on Health podcast. My name is Dr. Sean Lordan, and I'm here with Dr. Chris Vinton of Worcester County Orthopedics. Excited to have you on here today, Chris. And,
Appreciate it.
Let's just start by your background and tell us a little bit about yourself.
Sure. So I'm actually a New England transplant. I grew up in Washington, D.C., but came up to Holy Cross as an undergraduate. I was a biology pre-med major there and played football at Holy Cross 92 to 96. And got to know the team physician there a little bit and got into orthopedics. Went to Dartmouth Medical School. Did my residency at UMass right here in Worcester. And then I did a one-year sports fellowship at Brigham and Women Harvard program in Boston. Then started practice in 2007. So that's the brief intro. I'm married to my wife Amanda, and I have two kids, Molly and Mac, senior at St. John's and a senior at Holy Cross. That's the brief intro.
Excellent. Well, thanks again for joining us today, Chris. And I guess my first question is, what first made you want to become an orthopedic surgeon?
Yeah. So as I said, Holy Cross was where I was headed. Played football in high school. Played football in college. I knew science was always my go-to. I was a biology major at Holy Cross. That's just what came natural to me. And then started working with team physician Dr. Leahy Jr. Well, he was our team physician at Holy Cross. Got to shadow him, got to see what orthopedics was like. Immediately loved it. I'm a very hands-on guy. I like to solve problems. I like to work with my hands, and this was a perfect fit. So I went into medical school just thinking that this is where I wanted to go. Tried to keep an open mind, looked at other specialties, but nothing beat orthopedics. So that's it. In a nutshell.
It's great. And, so I know this, but Dr. Vinton is really known for his hip replacements in this area, and you're really the go-to guy for, the anterior hip replacement.
Yeah.
What sort of drew you to specializing on the hip complex?
Yeah. So as I said, I did a sports medicine fellowship. So I went into that and, through residency, primarily focusing on sports medicine. And then kind of fell into the joint replacement. We had a real robust joint replacement training during residency, so I was very comfortable with hip replacement. But then the sports medicine, focuses more on minimally invasive, faster recovery protocols. And so that kind of combined, and then I started looking at the anterior approach as a less invasive way to do a great surgery, hip replacement. And just kind of fell in love with it. And then just as I got busy, there weren't really anybody, no one else in the area was doing the direct anterior approach. And then my practice just went from more of a sports practice to a joint replacement practice, which is great because it's a great surgery and patients do fantastic.
Yeah, I feel like it's a good opportunity to just dive right into that.
Yeah.
Because, from my experience when I first graduated from PT school, really right around the time that you started practicing, it was a lot of posterior approach. That was kind of the mainstay of a total hip replacement. So the anterior approach was almost like a newer technique back then. And talk to me about that.
Yeah. So the actual approach for anterior replacement's been around for decades.
Yeah.
But it hasn't been the most popular approach to hip replacement. Some of that is just New England. A lot of people train here and then go into practice here, and the predominant way of training is posterior. Yeah. So I think that's sort of why it predominates, in the area. But then so even looking back, I started my training in 2000, and patients were coming in. They were spending 3 to 5 days in the hospital, and then most of them were going to rehab. To now I'm doing 50% of my joint replacements outpatient, going home same day, home PT, and then hopefully within 1 to 2 weeks into the outpatient PT world. So, so that's the trend is just that faster recovery.
Yeah.
And if you want, we can get into a little bit more of the details of the actual surgery and approach.
Yeah, 100%. I think that's talk to that patient, that person who's coming in, or they're coming in for the first time, they've got some hip pain, maybe they were referred by their primary care, and they've come see you first. So how do you kind of explain and educate a patient around?
Yeah. So the big first question is, are you ready? Do you need the hip replacement? And a lot of the things that go into that are, how bad is the arthritis? Really your arthritis should be in kind of the moderate to severe range. Joint replacement, as sort of minimally invasive as it is, it's still a big surgery, and it's a big commitment. You now have an implant, you got an implant, you got to protect, especially for younger patients. You can't bang on an implant the way you would your own hip. So first question is are you ready? And that's, how much arthritis do you have? Again, moderate to severe is sort of where you should be for that. And then what have you done for treatment? Have you had the conservative treatments? Have you had anti-inflammatories, injections, therapy? And then how much is that hip really bothering you? To do a surgery, it should be more than a nuisance. It should be more than like, yeah, it's a little sore after I, run 3 miles. It should be, this is starting to affect my life. This is starting to get to the point where I'm giving up activities that I'd like to do. I'm having trouble sleeping, having trouble with just kind of day-to-day stuff. So when you start to get through all that, that's when it's time to talk surgery. Yeah. And then the surgery, once we start talking about that, how do I educate people? Well, it's, I pull up diagrams, I kind of show them what the surgery, what does a hip look like, because a lot of people, they don't know what a hip replacement looks like, and nor should they, that's for us to know and us to educate. But so I kind of go through, show them what the implants look like, I show them what the approach is, and again, it's in the direct anterior approach, we're going in through the front of the hip, not the back of the hip, and there's a true plane between muscle groups, between nerves that you can get in, so you're not cutting any muscles off the femur, you're not cutting any muscles off of the pelvis. You're preserving all the external rotators, which are the main structures in the back of the hip that help really support the hip, prevent dislocation, and kind of restore function or preserve function. So we avoid getting into all that. At the time of surgery, we're using X-ray. So one of the big risks with any hip replacement is leg length discrepancy, or you're not matching one side to the other. Yeah. But with anterior hip, patient is flat on their back. They're on a special table that allows us to bring in an X-ray machine, and we can X-ray and compare directly during the surgery one side to the other, and it really helps reestablish patient's anatomy. Yeah. So the things that I tell people about, I tell them what the surgery is, I kind of tell them what the recovery is, but the things I focus on, it's more anatomic, because we're better able to match up your anatomy. It's more stable, so lower risk of dislocation because we're preserving all those. It's less invasive because we're preserving those muscles in the back especially. And then it's just a faster recovery. So average recovery is probably about half the time of a traditional posterior approach, and that's probably something you guys see, in your world here.
Yeah, and I think about just the total hips versus total knees in general, and how much faster I see total hips recover than total knees, and with much less pain.
Yeah, that's just the nature of the surgery across the board. So, even a posterior hip compared to a knee is an easier surgery to go through. Yeah. Part of it's the difference in the joint, part of it's the difference in the technology. A hip replacement really acts like a hip joint. A good knee replacement is good, but it does not replicate your native knee. Yeah. And so I try and point that out to patients. And then, so hips are better than knees, and then an anterior hip, obviously I'm biased, but in my opinion, that's even better than a posterior hip. Yeah.
Is there somebody who you think would benefit more from a posterior hip versus an anterior hip?
Yeah, so there are certain people that just aren't good candidates. There's certain pelvic anatomies that, if they have very short femoral necks, real wide pelvises, not a lot of offset, so the femur's kind of tucked up against the pelvis, those ones are tougher to do. Yeah. Those are cases where in your learning curve, you definitely want to avoid those. You want to take the easy ones. Yeah. Learning curve is different and difficult for the anterior hip. And your first 40 cases, you got to be real selective. First 100 cases, somewhat selective. And then once you get through that, you're pretty much through the learning curve. Yeah. At this point, I'll do pretty much any pelvic anatomy from an anterior approach. I don't do posterior approach anymore just because I've gotten comfortable doing doing pretty much everyone through the anterior approach. Some bad skin issues, if they have real significant overlying hanging skin, that sometimes is a contraindication. And then previous trauma, anytime there's previous surgery or hardware in the back of the hip. If you've ever had a posterior approach for a rotting, a nail, fixing a fracture, something like that, then you just sort of lose the benefit of going in through the front. And you're better off just going in the back to get the hardware out. So,
yeah.
But pretty much all comers at this point are anterior for me.
Yeah, and can you talk about, so you briefly touched on the fact you don't really have to cut through any muscle tissue. Yeah. Can you explain to patients why that's so important?
Yeah, I mean, so the joint, once you put the implants in, those implants are pretty stable. You're not having pain from where those implants go into bone. And, these are press fit implants. So you are relying on the body to grow bone into these implants to hold them in place. That takes about 6 weeks, but they're designed to be robust enough that you can put weight on them and you don't have pain from that. The pain and functional recovery from hip replacement in general is how much muscle damage, how much muscle stretching and work we're doing during the surgery. And the more you can minimize that, the faster people recover. So that's why we focus on that.
Yeah, that's great. Predisposing variables, right? So, are there any lifestyle habits that kind of speed up, Chris, that you've seen speed up hip degeneration?
So there's been studies on that, and I kind of look at things. People always come in and say, I played a lot of sports. And I think that most of the studies really support that if you're at a real high level, like NFL level sports, that probably does contribute to it. Yeah. But recreational athletics, even college sports, probably don't really accelerate arthritis. Yeah. There's definitely some anatomic differences, like femoral acetabular impingement. That's a big one. So with FAI, you've got sort of altered anatomy between the femur and the pelvis, and that can lead to early wear in the hip. And that's a clear predisposing factor. Yeah. We see that a lot with hockey players, especially goalies, and I think that does contribute.
Can you explain some of the symptoms of FAI?
Yeah, so FAI is going to be, so it's impingement between the femur and the pelvis, and patients feel that as groin pain, tightness, loss of motion. You're not able to, bring your knee up as much, especially rotational movements. So you're not as good side to side. You're not as good with squats and those lateral movements. Yeah. And you feel it in the groin.
Yeah, that's a tough one. And I guess let's talk about your differential diagnosis too, because I think that's an interesting part. When you're considering whether somebody's ready for that hip or not. Yeah. What else do you consider when somebody comes in? Well,
so you always look at, when someone comes in with hip pain, the first thing is where's that hip pain coming from? And what people say as hip pain and what I think is hip pain is different. And for people coming in, hip pain can be anything from low back, trochanteric bursitis, IT band, soft tissue muscle, SI joint, to true groin or true joint pain. True joint pain is usually more groin, kind of radiates down the thigh, sometimes goes into the knee, pain with squatting, pain with pivoting. Those are sort of more the joint symptoms. So first thing is, get through the differential, figure out, is this coming from the joint or not? And then from there, how much of it is really from the joint? And then you're looking at x-rays to say, is this a joint problem that's arthritis-based, or is it a joint problem that's not, like FAI, labral tears, something else coming from the joint?
Yeah, and can you touch on too, we don't see them really too often anymore, but like labral surgeries for FAI. Yeah. They were doing them out of the hospital for HSS for a while.
Yeah, it's still done. It is... So surgery for FAI is basically arthroscopic treatment for the hip, where you're trying to kind of shave down, bone spurs, shave down abnormal bone, to improve range of motion and decrease that impingement that's going on. At the same time, you can either debride, sort of clean up labral tears if the tissue's kind of beat up, or you can repair labral tears. I think the results on hip arthroscopy are a little bit mixed. There's some studies that show that at a year out, arthroscopic treatment of these problems and physical therapy have very similar results.
Yeah.
There's some studies that show athletes that have FAI surgery at a year are worse than people that didn't have that surgery. And then there's some studies that show, clear benefit from labral repair, labral treatment at 2 years out. So I always go over these with patients just to say the surgery is a little bit unpredictable, and it's a long recovery. So even though it's arthroscopic, it's 4 to 6 months recovery for these procedures. In ways, getting a hip replacement is a faster recovery because most folks are pretty well recovered 6-8 weeks out.
Yeah. No, do you ever? I've seen it probably a couple times in my career. 2 at the same time. What are your thoughts on that?
So it's a lot of surgery. I've done handful, maybe a handful and a half in my career. It changes the experience, and I think it really affects your ability to recover. So when we're doing a single hip at a time, most people are having spinal anesthetic, so not a general anesthetic. That spinal lasts under 2 hours. You're not getting a whole lot of other medication related to that. We treat your pain, but once that spinal wears off, you're awake and you're ready to move. You can't do both hips under spinal anesthetic. They just don't last that long, so that means you're under general anesthetic. You also have to break down one surgical instrument set and a whole setup. You do one case, you close that, you put the dressing on, break down the whole room, and set up the whole room for the other case. So the reality is if you have bilateral hips, you're probably under general anesthetic for like 4 plus, maybe even 5-6 hours.
Yeah.
That's a lot of general anesthetic.
And what are the side effects of that?
It's just, so overall, it just kind of wipes you out. You get a lot of people get nausea, confusion, you feel lousy for a while all that medication gets out of your system. There's not like a lot of risk difference in terms of heart, cardiac, pulmonary, between the spinal and the general for someone that's otherwise reasonably healthy. But it's a big stress and a big toll on the system. Yeah. And now you're trying to recover 2 at the same time. So I generally just don't think it's worth it, because the recovery is pretty quick from one. You can stagger them 6 weeks apart and, you're in and out of the surgery center if you're healthy in probably 4 or 5 hours, and recovering quicker. So I don't think there's a lot of benefit to doing the bilateral.
Yeah, I think it's a certain personality that says, I just have to do it all at once. Are they still doing like a lateral approach, a direct lateral approach? Is that a thing still?
So and so some of it is where you're trained, what you're comfortable with. I mean, the most common probably around here is posterior lateral. Some people are doing some more minimal incisions with that, trying to preserve a little bit more of the external rotators. Direct lateral or anterior lateral is side of the hip and either taking off a wafer of bone on the greater trochanter or taking down part of the abductors. And as you know, abductor function is critical for gait, balance, and limp. And so if you're relying on those, either bone to heal or tendon to heal during your recovery, you got to protect the hip a little bit more. And those are associated with much higher risk of limping after surgery. Some folks are doing that, but that's not a real popular or common approach these days.
Yeah. So in school, they taught us the anterior hip precautions were the exact opposite of the posterior hip precautions. Mm-hmm. It sounds like if you don't really need to cut through much tissue, that there shouldn't really be too many precautions.
So I don't put people on formal precautions. So formal posterior precautions back in the day were, you can't bring your leg past the midline. You can't cross over past the midline. You're not supposed to bring it up past 90 degrees, and you can't internally rotate. So that'd be a posterior precaution. Anterior precautions where you couldn't go into extreme extension and external rotation. I don't put people on any precautions in particular. I just say, for the first 6 weeks, be cautious. Don't be paranoid, but be cautious. You can do your normal day-to-day activities. You can use a regular toilet seat. You can do your socks and shoes when you feel comfortable. Don't do yoga. Don't do crazy stretching. I've had people do yoga at like 4 to 6 weeks, and you're like, what are you doing? But as long as they're doing kind of normal day-to-day activities, you don't have to be paranoid. So so for them, it's much less limiting on what you can do. You can get in and out of bed as you feel comfortable, in and out of a car as you feel comfortable. And even most of the posterior surgeons are getting away from real strict precautions because as the implants have gotten better, things are more stable.
Yeah, that's good for PTs to know, or who may be listening, because one of the big things, as you were just talking, was glute med strength, and people need to be able to bridge and roll to get out of bed.
Yeah.
That's always something that really one of the first things that I would treat, is the glutes, med, glute max.
Yeah.
So that's, it's a huge pro to be able to extend, early on. So that's awesome. Let's talk about myths around hip pain.
Okay.
Is there anything in particular that kind of, comes to your office and people come in and they're like, just give me, bust some myths around hip pain?
Well, so again, I think a lot of it is kind of like what I touched on earlier. A lot of people sort of interpret pain and they say hip and it's not really coming from hip. And so that's really the first step, is looking, is this coming from the back, and trying to determine whether it's true hip pain or like a sciatica. The other big one is trochanteric bursitis. So IT band problems, trochanteric bursitis is probably the number one non-joint thing that we see as hip pain. And so just talking to patients about, this is a soft tissue problem, this is a tight tendon problem versus a worn out joint problem, and what's the difference? That's sort of one of the big things. And then the other sort of big thing that we'll see is there are some folks that have terrible hips that don't have hip pain but present just with like thigh or knee pain. And you get them into your office and you examine their hip and they've got restricted motion, they got they have pain when they do that, they complain about their knee, they examine their knee, they have no tenderness, normal looking knee exam. You x-ray both their hip and their knee, and often you'll see a bad hip and a normal knee, and then trying to explain to them that, like, no, this is your hip, not your knee. A lot of times it takes them a little time to come around to that. But
that's the, for us, the PT equivalent of that is when people have, pain in their shoulder and they point to the insertion of the deltoid.
It's right here.
and it's, it's scapulothoracic rhythm. That's a funny, and I feel like PT, Chris, can be diagnostic in that case too. Go see Sean for 6 weeks or go see a physical therapist for 6 weeks. And if that solves because the IT band problems are just,
that's
mechanical.
Fixable, right?
And I think, for a lot of this stuff, it's, I feel like PT can be diagnostic, because if it fails and they're not better, then it's truly like, hey, it's, it's the joint.
Something deeper, more structural and underlying.
Let's kind of dive in a little bit to the combination of physical therapy and surgery, and what do you feel like truly is the best use of rehab, and how do you see the best rehab happening after surgery?
So unfortunately we live in a day where some of this is constrained by insurance, and some people only have so much to do, and how do you use it? I definitely think that people that come into surgery stronger, better balance, better mobility, they do better, because they're just sort of coming in at a better place. Very early on, the initial post-op is more how do you kind of protect yourself a little bit and do your normal day-to-day activities. And that's the first couple weeks. But again, since people are recovering fast, we can get these people transitioned to the outpatient and really get working on strengthening. Big thing with the implants that we're using these days is you just don't want to do real heavy lifting or impact, because it takes that 6 weeks for your body to ingrow bone into those. They are designed for weight bearing. They do well with just day-to-day weight bearing. You just don't want to stress them out. So with the one exception of not doing anything too extreme in that first 6 weeks, getting into early outpatient PT and really kind of working on the muscle strength and motion is definitely beneficial.
And then I totally agree. I think when we see patients for 4 weeks before rehab, and again, if the insurance is amenable to that, that's huge. The outcomes are just going to be better because the tissue's stronger. So you go in, obviously there's going to be inflammation and things happen, and you're going to lower that baseline a little bit. And you're going to get back
temporarily.
Exactly. So at that 6-week mark, we kind of think about, tissue healing timeframes, 4 to 8, really 6 to 8 weeks, kind of things solidifying.
Yeah.
Talk to me about return to sport.
Sure.
So that's the most common question we get, Chris.
Absolutely.
Is hey, when can I play pickleball?
Yeah.
When can I go back to golf? When can I run? Is it possible to run? Those sort of questions.
So I kind of break that down into kind of a couple different phases and couple different groups of sort of sport. Walking and stationary bike, kind of low resistance, even like 2 weeks out. You can even start that at home. You can start moving. Just that really promotes that joint mobility, getting those muscles moving again. So you're not loading things too heavily, but you're at least starting to get some motion back. For the golfers, that's a big question. When can I do what?
Yeah.
Chip and putt, I usually tell them 2 to 3 weeks. You can start working on that. Full swing, 6 weeks. So that's sort of my go-to for that. For people that want to get back to the gym, lifting, I usually say, right around that 4-week mark, you can start to get back, start doing some real light strengthening at that point. Don't do, maxes and try and really push it. If you're a biker, getting on a road bike or really starting to push resistance is about the 6-week mark too. And then ultimately getting back to sport, things like pickleball, start, stop, side to side, that's probably going to be closer to, 3 months for something like that. Running, same sort of thing. The big question is should people with joint replacements run? And that's a tough one to answer because there's not a scientific answer to that. Yeah. Common sense being common sense, the more you load it, the more you impact on it, the more cycles you put on it, the faster that bearing, that plastic is going to wear out. Plastic is way better than it used to be. We're using mostly ceramic on plastic bearings these days. These are very, very durable. They're, if you look at big studies, they probably fail at about a rate of 0.5% per year. So, people ask, how long is my implant going to last? And you can't say, well, it's got a 20-year shelf life and then it's going to fail, because it's not like they all go 20 years and fail. Yeah. They fail over time. So I tell people, 90% chance at 20 years your bearing is still working. Common sense being common sense, if you pound on it, that's going to be, lower likelihood. But no one's ever looked at, and it would be very hard to do a study, runners versus not runners. You'd need thousands of patients because the wear rate is so low. You need thousands of patients over a long period of time to really appreciate a difference.
With the same implants.
With the same implants, and no one's going to do that. It's just a question that doesn't have enough bearing, to warrant answering. So I tell them, look, physically you're going to be able to run. People feel comfortable running on these things. It's probably not supposed to, should not be your most common form of exercise. If you want to go do a turkey trot, a little 5K, do something with your family, do that. But don't pick up long distance running. Don't become a marathoner. Yeah. And definitely it's the 3 to 4 month range before everything's solid, your muscles are where they need to be to start doing that.
Is there a particular strength test? Because, the big thing in ACL is, you get all these different tests. Is there a particular test that you look at, Chris, that...
I don't. I look a lot at gait. I think, like you said, the glutes are the big thing. The abductors, the max, in terms of gait and return, those are probably the ones that give you the most control.
Yeah. So, what Chris is talking about for the audience is, we can tell pretty fast, if the gait is off, because there's a couple things like hip drop when you're walking. We call that a Trendelenburg gait. That tells us that your glutes are weak. And I always say that PTs would be out of business if people did sidewalks. Yeah. Because a lot of what we do is, forward and backward and in front of us during the day, and it's not lateral motion. Right. Same thing for the upper body with the, the openers. Yeah. But I'm glad that you brought up the lifespan of a hip, because, again, 15 years ago or 20 years ago when I just graduated, we were talking about cemented versus uncemented, and patients were talking to their physicians about that at that point. Right. And it sounds like now that's sort of the past.
Yeah, I think, pretty much standard of care is an uncemented, bone ingrowth implant. Lots of different designs. We template. We use sort of 2 major designs. And it's really kind of based on your femoral anatomy. So we have x-rays in the office. We have a digital templating system. We can overlay the implant on the bone and say, does this fit? Does it not fit? We're looking at trying to recreate your anatomy, matching you up to the other side. So we look at that first, but really cemented implants are pretty few and far between these days. Sometimes we'll use them for fracture if you're doing a partial or a total hip replacement for fracture. There are patients that just are, bone quality just doesn't support using an uncemented implant. And then the bearing choices, sort of in my training, early was metal on standard uncross-linked polyethylene, and that generated a lot of small polyethylene or plastic particles that generated a tissue response that could eat the particles but also eat bone, and so you got osteolysis or bone loss because of that, and loosening. And that really is going away as we've started cross-linking or treating the polyethylene to make it more durable. There was a period of time in the early 2000s, up to about 2010, where we were using a lot of metal on metal bearings. A lot of those did very, very well, but some of them have had problems with metal debris, metal wear, metal ions in the blood, and it was a thing where you probably were under the threshold of detection when they first came out and when the numbers were small, but as the numbers grew, now you're starting to see it. So those are pretty much gone off the market. Most people are using some form of a ceramic ball and a cross-linked or treated polyethylene.
Yeah.
So
it's a good segue into technology.
Yeah.
So let's talk about what excites you, for the next sort of 5-10 years of doing hip replacements and medicine in general for technology.
So I guess the implants, the bearings are getting pretty good. Maybe there's going to be some incremental improvements in the bearings, increasing femoral head size, increasing like some of these dual mobility cups for stability. But instability is really decreasing. I think we're in the well under 1% risk range for an anterior hip with modern implants.
And give the audience sort of a perspective, Chris, for a posterior
historically
approach.
Yeah. I mean, so historically, so let's go way back. When hip replacement was first invented, you were using these tiny femoral heads, so 28 millimeter femoral heads, and the neck is not much bigger, and you've got a big plastic with a small little hole, and so you did not have much of an arc of motion before that thing could pop out.
Yeah.
So historically, dislocation rates were upwards of 10%. As implants improved, your plastic becomes thinner, your femoral head becomes bigger, and that gives you a bigger arc of motion before you risk popping it out.
Yeah.
Jump to the anterior approach, now you've got better implants and preservation of muscles and soft tissues that prevent dislocation, especially obturator internus, one of the strongest anti-dislocators. You preserve that, and you're using better implants. Our dislocation rates are way down, but historically, it was a big issue. Upwards of 10%.
Yeah.
So something that patients had to think about for their entire life. Now we kind of say, like, if you get through the first year, 86% or something of dislocations happen in the first year, with most of those in the first 3 months. So that's why I say, don't be paranoid, but be cautious for that first 3 months. And then as you get further and further out, you don't have to think about it quite as much.
And then in terms of dislocation, so have you ever repaired anteriorly a hip that's been dislocated from a posterior approach?
So that's tough, because you have to look at, so for one, adding another approach to a previous approach can put you at risk for dislocations, because even though we're not disrupting a lot of soft tissue, we are going through anterior capsule, we repair it, but that is another approach to the hip. So usually if you have an instability issue from a posterior approach, you'd approach that back through a posterior approach so that you can reorient the cup. There are some liners that change some of the angles. So if it's dislocating, you gotta say why. Is it a length issue? Is it an offset issue? Is it a cup position, femoral head size? So there's so many things that go into it. You gotta identify which one of those, and then what can you do about it. And often you end up just going in through the same approach just because you're not adding anything to it.
Yeah, but it sounds like you haven't had to do that, which is pretty nice.
I in my practice, instability has really been a very, very low incidence thing. And even since I started, even over the last couple of years, the polyethylene has improved to the point where some of the smaller women were coming in, and typically the cup size, the size of the cup that goes in the pelvis dictates how big the liner is, which dictates how big the femoral head is. And a lot of women are in that 48 to 50 millimeter range, and that traditionally got you at a 32 femoral head. Now we can get a 36 femoral head in there. So that increases stability right there. Yeah. So even in the last couple of years, you've got one more thing kind of getting rid of instability. So instability, thankfully, I will say, has not been a big issue for my practice.
Which is great. And that's the biggest thing with PT is, our fear as PTs is that somebody's going to dislocate.
Right.
It's happened. It hasn't happened to me in particular, but it happened twice, with another PT in a clinic that I used to work at. Yeah. And it's a scary thing. People are excruciating pain when it happens. A
lot of pain, trip to the ER.
Yeah, no fun.
Often back to the OR for a reduction, so not something you want.
Yeah, so it's great to, I love when I see an anterior approach because I'm like, all right, great, it's going to be stable. We can and it's going to be a faster rehab.
Yeah.
Talk to me. One thing I forgot to mention was, or to talk about, was the nervous Nelly, right? So the patient who gets in, and they're like, is now the right time? And you were kind of touching on it a little bit before, but when do you know, when do you know when to push somebody toward it, and when do you say, hey, let me steer you toward PT or something?
So first of all, again, as a doc, it's identifying what they're nervous about. Are they nervous about the process, and then you kind of touch on the different things, the recovery, the anesthesia, the actual surgery. You can kind of, a lot of times education really helps with their, anxiety on that. And then is it, nervous in terms of, am I ready? Well, that's a tough part. And I try and guide them. I try and tell them, these are the things you need to think about, but it is a personal decision.
Yeah.
And the things that I'll look at is, how bad is the arthritis? If it's bone on bone and you're starting to flatten the femoral head, or you're starting to wear out the socket, I tell them, look, this is going to get worse. This is going to get worse in a relatively short period of time. Yeah. You just need to fix this before you do something where it changes the surgery that we can do.
Yeah. Or it affects other things up and down the chain.
Yeah. Age is a big thing. So if you're 70, healthy, with a terrible hip, chances are you're going to go through that hip replacement pretty easily, and that's the only hip replacement you're going to need. So what's the real reason to put that off? There's not a good reason to put that off. Yeah. It's more if you're in your 40s or 50s, if it's in that moderate to severe range. Those are the ones where it's a little bit more of a discussion. Are you ready for it or not? And then ultimately it comes down to the same things we talked about. Have you tried some conservative treatment, therapy, injections, anti-inflammatories, activity modification? Mm-hmm. And then how much is it affecting your life? It should be, you don't need to be debilitated. You don't need to come in a wheelchair and say, I'm ready. Yeah. But it should be more than a little bit of a nuisance. If you can take some anti-inflammatory, or if you're sore for a couple days after an activity, but it doesn't limit you, you're probably not ready.
Yeah. And I think that's the beauty of collaborating with PT, right? So it's if they're on the cusp, that's where PT can be diagnostic too, mm-hmm. right? Hey, go do PT for 6 to 8 weeks. If it helps, great.
Right.
Especially if they're 40 or 50, you really kind of want to put that off until probably 60 at least.
So we kind of throw around 65. 65 is kind of the magic number. If you get to that age, statistically, pretty unlikely you'll need a revision.
Yeah.
40 and 50, pretty likely you'll probably need something at some point in your lifetime. But, I always tell people, I don't have a crystal ball. I don't know what the future holds. You do it when you're ready, and you do it because it's affecting your quality of life. And that's really what it comes down to.
And it's funny, Chris, because, we see on the other side sort of, I see the whole picture. I see people with the hips, the knees, shoulders are becoming
mm-hmm.
more common now too. But for me, the toughest patients are the 85-year-old, right? Who really probably needs that new hip or revision, or probably just never got one and just needs it now. And they're almost too medically compromised to get it. And those are for us, those are the tough patients.
And same thing for us. Those are tough conversations. But again, it ultimately comes down to a quality of life. And if you come in at 85 and you're on the fence, I tell you, look, you got to make a decision. You got to make a decision quick, because if you wait even a couple more years and things get worse, you might even be in a worse position. So that's when we reach out to the primary care. We reach out to the cardiologist, and we try and really get that patient some reasonable information. How, age goes into it. Age, the number plays a role, but it's not the only thing. And how healthy in 85 are you? And if the cardiologist says, you're pretty good. You don't have a ton of risk. If we put you in the low risk category, then maybe do it and do the anterior, recover quick, and enjoy whatever the number is that's left.
Yeah, I think that's huge. The quality of life. Yeah. All right, let's wrap with a fun one.
Okay.
So I gave you a little preparation on this.
Thank you.
So, if you could have dinner with any three people, Chris, living or dead, who would they be and why?
Okay. All right. So I had to do a little thinking. Number one, Joseph Lister. Joseph Lister is a father of modern surgery, practiced in like the 1800s, early 1900s, and really was the first one that identified antisepsis, so hand washing, surgical prep, and changed surgical outcomes by decreasing, bacteria, making it a cleaner surgery, and patients actually did better. And we learned from that. So he's sort of credited as the father of modern surgery. So I think that would be a interesting person to talk to, way ahead of his time, obviously. Smith Peterson is credited sort of with the introduction of hip replacement in the probably 1920s. Smith Peterson actually used an anterior type approach. So sort of the father of modern direct anterior total hip. So again, outside or ahead of his time and sort of thinking outside the box. So I really like to think about those innovators and would love to pick their brains. And then third was a fun one, Seth MacFarlane. You got to throw someone in just for pure entertainment value. I think he is a very intelligent, witty guy, but he sort of pushes the envelope, and I think he would make the dinner party perfect.
I mean, that sounds like a dinner party I definitely want to be a part of.
Right.
That's cool. Favorite book that you've read recently?
Oh boy, that is a tough one.
I got to put you on the spot for a couple of these.
I know. You didn't give me that one as a heads up. So I forget, it's Sapiens. So Sapiens, and I forget how to pronounce the author, but Jewish historian, and really looked at like the history of man and the evolution through language, storytelling. How did we become sort of who we are today? That was a pretty interesting book.
That's good. Would you say you're more nonfiction than you are fiction?
I'm not a huge reader, I have to say. I read a lot for work. I spend a lot of time, in the orthopedic literature, so it's not always my go-to. I tend to do more hands-on activities when I'm not at work.
Yeah, what do you like to do hands-on?
So I'm a builder. So that's sort of my go-to. I like to built a couple barns at the house, remodeled the kids' the kids' bathroom. I'm working on a basement remodel now.
Yeah.
Like construction. Built a sauna. So just hands-on, using tools. I like using tools at work. I like using tools at home. I like to see the project come together. I like to see something sort of a finished work, and you say, I did that.
Yeah, that's cool.
Yeah.
I mean, that's definitely aligned with,
with
what you do for
that's
work.
Not a big deviation from sort of the rest of my personality.
Yeah, that's cool. That's awesome. And then last one is favorite movie.
Favorite movie. All right. Well, I'm gonna stick with Seth MacFarlane and A Million Ways to Die in the West.
Okay.
For that one.
Awesome. Perfect. Well, got Dr. Vinton here today, and thank you so much, Chris, for joining us. And anything else you'd like to share with our audience before you?
No. I think we covered a lot of stuff, and I think we had a great discussion about certainly orthopedics and hip replacements in particular.
Yeah. So if you need a sauna, Chris has one in his backyard.
Yeah, there you
go. we won't include his home address in the show notes.
A lot of health benefits to that. Some big Finnish studies show big decrease in sort of all time or all coming mortality for frequent sauna use. So
yeah, it's exciting.
It's good for the body.
And just a shameless plug here, we've got a sauna and a plunge tub at our recovery room here at our main Sutton location as well. So super excited to have you on today, Chris, and we'll include an email for your office and your website in the show notes. And,
website's worcesterortho.com, and we'll get that in there, and it has all the practice information and some good patient information on there too.
And there's also some other tremendous doctors at Worcester Orthopedics. They can see really any sports medicine injury.
We can see any age group, any sports injury, a recreational injury, traumatic injury, wear and tear, sort of throughout the gamut, and good availability.
So thanks again, Chris, for coming on today, and
all right, Sean.
It's been a pleasure.
Yeah, thank you. Appreciate it.